Okay, and I think with that we'll get started. Welcome back to ORALM 651. I don't know where you are by now, but you're definitely lost. I'm Keegan. I'm one of the student leaders. Speaking of being lost, if you don't know how to fill out your outreach, how to log your hours, stuff like that, you can look up some of the resources at helpinghomelessness.com. Or if you're having problems finding opportunities, stuff like that, you can email either me or David, or come talk to us. Please sign in and do a speaker evaluation. Don't sign in for anyone else. There we got it. NASW approval. Okay. Without further ado, it is my pleasure to introduce Ron Jackson. Mr. Jackson has been working as a clinician, administrator, educator, researcher, and consultant in the field of addiction treatment since 1972. Until 2013, he was the executive director of Evergreen Treatment Services, a private nonprofit organization in the Seattle and Olympia areas. He's here to talk to us today about the Evergreen Treatment Center and Harmony. That's the mission statement right up there. Without further ado.
Great, thanks, Stephen. That's me at my retirement party, huh? I'm still done with it. So, how do I get this to go? Cool. Okay. So I'm here to talk about harm reduction. And which is not the traditional approach that's used in the treatment of addictive disorders. And so I'm going to talk about it from a couple of different perspectives. I always like to start talks by reminding folks what addiction is and how it's different than simple misuse of the substance. A lot of people want to think of addiction as willful misconduct or a bad person doing a bad thing. In fact, it's a brain disease. There are changes that make people, there are genetic and neurochemical abnormalities that make individuals more vulnerable to the reinforcing properties of drugs. So some people are more attracted to drugs than other people. If you take a look at prenatal alcohol exposure in infants, those infants, this is both in human and rat studies, those infants have more of a preference for the taste and smell of alcohol than individuals who were not prenatally exposed in utero to alcohol. So it's not just genetics, it's not just fetal environment, it's also true about social environment and family unit growing up and so forth and so on. Alan Leshner is used to be the director of the National Institute on Drug Abuse. He's the executive, he's the CEO of the American Academy for the Advancement of Sciences now, and he went around the country in the late 1990s, early 2000s, talking about an addiction as a brain disease, to talk about what the National Institutes of Health had learned about the sort of neurochemical substrates of addiction, both what acute use looks like and what happens to the brain as a result of chronic exposure. He did it to talk about what they learned and also to try to address the issue of stigma. Most people who struggle with their relationship with alcohol and other drugs, their pathological relationship with it, are afraid to talk to anybody about it, particularly medical and dental professionals, for fear of being judged as a bad person. The second, and this is one of the leading problems in the delivery of care to those individuals. It starts everywhere from early diagnosis and treatment to the placement of specialty care clinics for addicts and so forth. The next quote comes from Nora Volkoff. She is the current director of NIDA. She's an addiction psychiatrist, and for 10 years before becoming the director of NIDA, she was the director of neuroimaging at Brookhaven National Laboratory, and it was in her labs that they began to understand and study in more detail what was going on in the brains of addicts and how drug taking not only hijacked the brain's reward pathways, but also downregulated the area of the brain that's the prefrontal cortex that you know is responsible for impulse control. So you have people who are who learn to like a particular substance, like everything about it, the smell, the taste, the people that they do it with, how it makes them feel, and they have, as a result of their chronic use of that substance, increasing difficulty in controlling their impulses. It helps you understand why the person who's subject to a drug screen urinalysis from their probation officer the next morning goes ahead and uses that evening. It's not that they're stupid, it's rather that they really can't stop themselves. And so learning the treatment of addiction is involved materially in learning how to identify what the triggers are and learn how to deal with those cravings. The last quote comes from the late Susan Sontag, who talks about if we don't understand an illness and we think of it as mysterious, we tend to fear it. And that's what's happened with drug addicts. What's the principal approach for drug addicts in this country over the last 80 years? Lock them up, right? Because they're a danger to our community. They are literally agents carrying this virus that people think of as addiction. In DSM-5, we've just gone through the process of revising from DSM-4 to DSM-5. Here are the 11 elements that are necessary for the diagnosis of addiction. And with DSM-4 to DSM-5, there was a change. In DSM-4, there was a category called abuse. And that category went away in DSM-5 because there was no real empirical support for this notion of abuse. It was more oftenly observed as a subjective judgment about the person's use. In other words, there were people who said, if you're using an illegal drug at all, that's abuse because you're breaking the law. And that's really not empirically supported as that. So the developers or the revisers of DSM-4 kind of took a look at a variety of different things and said, we're going to have this thing called substance use disorder. It's no longer called drug dependence or drug abuse. It's called substance use disorder. And there are, by drugs, there's alcohol use disorder, cannabis use disorder, and opioid use disorder, and so forth and so on. And there are the qualifiers. And the qualifiers are determined by the number of symptoms that are observed or reported in the individual. I want to point out the first two symptoms of tolerance and withdrawal. As dental professionals, you may be prescribing to a patient opioids to which if they take them exactly as you ask them to do, they may develop tolerance. And when they run out of that medication or decide to quit or whatever the case may be, they might experience mild withdrawal. That tolerance and that withdrawal is no longer counted in DSM-5 diagnosis because it was prescribed by you and taken by the patient as you directed. That's a big departure. Physiologic dependence has been one of the elements of addiction diagnosis for several generations, and this is one of the big departure points with that. Also in DSM-5, this is the first time that craving was recognized as one of the criteria, and to be a drug addict is to suffer from craving, not just for hours and days after the drug and you stop taking the drug, but for months and months and months, and maybe even longer. And the reason for that is Pavlovian conditioning. That's how people get triggered. They have taken drugs in response to a wide variety of internal and external stimuli, and those stimuli still exist in their fields and recovery. Here's a quick run-through about what the changes have been. The gambling disorder is now lumped or grouped with substance use disorder simply because the fMRIs and other kinds of brain imaging studies show the same kinds of brain patterns as a result of with problem gamblers that they see with cocaine addicts and heroin addicts. This is also the first time that cannabis withdrawal has been added to the diagnostic and statistical manual, and so it's been clearly defined and there's empirical support for that. Caffeine withdrawal is there, and caffeine use disorders are in what's called a study section. Section 3 of DSM-5 is referred to as the study section, saying we need to learn more about that. So a lot of people want to think of addiction, particularly patients want to think of addiction as an acute disorder. And so you go to rehab and you get fixed, or you take a medicine for a brief period of time and you get fixed. It's not that. It's a chronic medical disorder because it looks, it behaves, its origins are very much like other chronic medical disorders. It runs in families, just like mental health problems, just like diabetes, just like hypertension. So there's a genetic heritability. If you have 100 alcoholics in a room, 50 of them will be family history positive. But 50 of them won't be family history positive. They will have behaved themselves into alcoholism, just like you can behave yourself into hypertension, you can behave yourself into adult onset diabetes and the like. So that's the voluntary choice. You know, I'm fond of saying that the most important decision that you can make in your life is choosing your parents well. But because it's not just nature that predisposes you to a higher probability of addiction, but it's also the environment in which you're raised. If you're raised in a chaotic family where there's one parent absent, or sometimes both parents are absent, you're raised in a social environment where drugs are readily available, where drugs selling is a means of economic support, that's a whole lot different set of circumstances than a stable family in a non-drug-infused environment and so forth and so on. You know that with adult onset diabetes, your body has become insensitive to its own insulin. So there are, in that case, neurohormonal changes that have occurred. In the case of drug addiction, there are changes inside the brain. For example, when you take exogenous opioids for a protracted period of time, your body starts down-regulating its own endogenous opioids, and one of the $64 billion questions in addiction science is how much drug taking does it take to permanently dysregulate the brain? We see that in a lot of our methadone maintenance patients. They are people who cannot maintain a drug-free state. They can't. Once they are off of a replacement medication, they are back to using street drugs almost inexorably within a relatively short period of time. If you think of adult onset diabetics, there are some who are going to be able to, with the support of some medicine, change their behavior and go on and wean off of the medication and keep their blood sugar within normal limits, and others can't do that. And the same is true. What we don't have is the level of science to inform patients into which category they fit. A short term of medication, an intermediate term of medication as a platform for neurochemical stability while they change their lives, or indefinite medication even though they might change their lives. And you can imagine to a 25-year-old heroin addict how vexing it is to think that you might have to be on this medication for the rest of your life. And the reason I use the 25-year-old is that's the cohort of new heroin addicts. We see new heroin addicts more in the 18 to 25-year-old category than we see them in 30s and 40s and 50s. I just came from a meeting where we were looking at the data about that. There are medications that are effective in the treatment of addiction. They're terribly underutilized. There was an article in the New York Times last week that talked about the underutilization of two medications, naltrexone and acamprosate, that had been approved by the FDA for the treatment of alcoholism, and they're not used very much. And I'll kind of go into that for a little bit. This was kind of on the heels of a meta-analysis about the effectiveness of those medications published in the Journal of the American Medical Association just last week. Tom McClellan and his colleagues that wrote this article, that was published in JAMA over almost a decade and a half ago, were actually invited to write this article. They were trying to change the conversation about addiction from being an acute disorder where you go to intensive outpatient, or you go to the Pines in North Carolina, or you go to some place where you get stone massages and hot tubs in Hawaii, and you're fixed. It's just not like that. The analogy that I like to use actually comes from dentistry. If I have a toothache, I go to my dentist, and my dentist works on my tooth and restores health to that tooth. They do whatever that they need to do. Does that dentist discharge me from care? Of course not. That dentist is going to send me a card or an email in a few months saying, we need to come back in, get your teeth clean, look at this, that, and the other. It's going to be an ongoing delivery of care. And that's exactly the model that is indicated for the treatment of addictive disorder. There may be acute episodes where they need intensified services by specialty care providers, but there also is an ongoing need for different kinds of tools. So the goal of addiction treatment is not curative. The medications that we use to treat opioid addiction, whether they're methadone or buprenorphine or naltrexone, are not curative of the person's addiction. They are simply management tools, in the same way that hydrochlorothiazide or lisinopril are not curative of a person's hypertension. They're simply management tools, aren't they? So what we're doing in addiction treatment is to try to get people the right tools, teach them how to use them so that they can manage their chronic disorder over time. And that's really the issue. And it doesn't necessarily mean that abstinence is the goal of this intervention. That's an important point. Sure, it would be great to take this 45-year-old heroin addict that's been using heroin and cocaine and alcohol compulsively in an addictive fashion since they were 14 years old. So they've got 31 years of addiction under their belt. You give them a little bit of treatment and they're fine again, but it just doesn't go like that. It's going to be a process, not an event, as we like to say. So let's talk a little, I'm going to shift gears and talk a little bit about harm reduction now, and not about traditional, this is no longer about traditional abstinence-based treatment. So this is a way to kind of think about the harm reduction approach. It is coming from, first of all, this humanistic notion of compassion for the individual. These aren't bad people, right? They may have made bad choices in their life. They may have done things that they later regret in their life, but they are not bad people. And we need to be hopeful for them. There's actually some literature to support the importance of the clinician's hopefulness in helping promote recovery in the individual. And you need to use a pragmatic approach with them. What I mean by a pragmatic approach is meet them where they are and engage them at the level that they can be engaged and understand that that engagement process is going to be an indefinite process, not just for the next 6 weeks or for the next year or whatever the case may be. This definition originally arose from Alan Marlatt, the late Alan Marlatt, who was a professor of psychology at our school here, and Susan Collins, who is a research, I don't know whether she got promoted or not, but she's a research professor here at the School of Medicine and Psychiatry and Behavioral Sciences. So here is a not exhaustive list of the harm reduction approaches that have been used in the past and are currently in play. And the reason that I've listed those is that these are all in play in our community. These aren't just taking place in Midtown Manhattan or in Albuquerque or in Lower Mainland, BC. These are things that are taking place here, with the exception of safe injection rooms. So methadone-assisted treatment of opioid addiction was really the first of the harm reduction interventions. It's been around since the late 1960s, and there are several 100,000 people in methadone treatment clinics around the country. And I'm not going to spend time talking about the intricacies of methadone treatment, because if I did, I wouldn't have time to cover some of the other more innovative things. But basically, it's medication and counseling coupled with urinalysis and social case management to help people achieve a recovery trajectory. And most methadone clinics do not discharge people for relapse. They stick with them and try to help them figure out what it was that led to that slip or what led to that relapse, and try to keep them in treatment, because they will do better. If you think of it as a chronic disease, they're going to do better with attention than with no attention. Syringe exchange programs in this state were really pioneered by Dave Purchase, the late Dave Purchase, in Tacoma and the Pierce County Health Department. Now they are everywhere throughout our state. In some cases, they're actually operated by the health department. So there are a number of needle exchanges here in our county operated by Seattle-King County Department of Public Health. There's one that's independently operated, exists in the alley, kind of right near the bookstore. It's run by the People's Harm Reduction Alliance, and the idea here, it had its origins with the advent of HIV disease, that the idea was that you would give injectors who were used to sharing works, both syringes as well as cottons and bottle caps and the like, and thus potentially exchanging bodily fluids and passing along HIV, and of course, even more predictably, HCV, and you would give them access to this safe way of reducing the probability of harm. And so they've been, in our community last year, there were over 5 million syringes exchanged between all of various places. And actually, there's a higher per capita exchange of syringes in Grays Harbor County, Aberdeen, Hoquiam, than there is in this particular county. So some of you may know that heroin addiction is rampant in more of the rural and suburban areas, not just in our state, but in other states. You might read the New York Times, you will see about the problem of heroin addiction in Vermont, and so forth and so on. So increasingly, communities around the country that would have never countenanced opening a methadone clinic in their community now are in support of it. Right this moment, right as I'm talking, the DEA is doing its final inspection so that we can open a methadone clinic in Hoquiam. And we had an enormous support from all levels of that particular community, from mayors and county council and police chiefs and fire chiefs, because they understand the importance of a harm reduction approach to this. They tried abstinence-based approaches with these individuals, and they either wouldn't go, or if they went, did not respond well. In lower mainland BC, there are safe injection rooms. This is places where individuals can come and use safe injection techniques in an observed fashion. They're not in the United States, and I suspect that there would be a huge amount of political opposition to the siting of them. So we'll see how that goes. A newer trend in terms of housing, it used to be that if Ron was alcoholic and he was homeless, for him to get housed somewhere, whether it was either in transitional living or in Section 8 housing or something like that, he had to get clean and sober. And of course, it was real hard for Ron to get clean and sober while he was homeless, and so increasingly around the country, you see a movement toward what's called housing first. That means Ron gets to get housed, even though he hasn't stopped drinking. And one of the primary places for that, a model for that, is the Downtown Emergency Services Center 1811 building. It's right there just to the west of I-5, kind of near the Convention Center underpass there. And it's been operating for a number of years now. It was rigorously studied by Mary Larimer, who was a colleague of Alan Marlatt and Susan Collins, and found that in putting those individuals who are still allowed to drink while in their housing significantly reduced their utilization of expensive emergency room services. So that's the harm reduction there. You're trying to help this person be healthier and not be using the emergency department as their primary care provider. A new movement all around the country is something called Screening, Brief Intervention, and Referral to Treatment, or SBIRT. I'll talk a little bit more about that. It conceptualizes either emergency departments or primary care providers as the first place to do screening, because most of the people who have problems with alcohol and other drugs are not the addicts. They are people who are using at a larger amount and more frequently than they should, but they haven't moved all the way to addiction. And so they don't need specialty care. They need briefer kinds of interventions to help them not necessarily stop their use, but reduce their use to moderate or safer levels. And I'll tell you a little bit more about that. We, in my agency, was awarded the contract to be the case management for something called the Law Enforcement Assisted Diversion, which is another harm reduction project in collaboration with the Seattle Police Department and a bunch of other partners that you'll see here in just a little bit to try to intervene with low-level drug offenders and street-based sex workers in the Belltown area, and now it's expanding to all of downtown to help them have a better life and be kind of less of a visible nuisance to the business and convention and downtown resident community. And then last but not least, a project also taking place within my clinic is this extended release naltrexone and harm reduction counseling. This is the first grant that the National Institute on Alcoholism and Alcohol Abuse gave, where the clear intention was not abstinence but harm reduction. And the description of the study was just published online this week. There's the link to it. David, they have a handout. Yeah, so this slide is in your handout. So it's free, it's online, take a read. It was interesting responding to the reviewers' comments. Clearly, some of the reviewers were struggling with this notion of harm reduction as compared to abstinence for these individuals. More about that in just a second. Am I going too fast? Is everybody okay? Cool. All right, so this is, oh, that looks weird. This is screening and brief intervention. So this is the whole idea. It was a model that was actually pioneered in Seattle by an emergency room physician named Larry Gentilello. And the idea here is that when people show up in the emergency room, that's a teachable moment. They are there because they were in a car wreck because they were intoxicated, or they were in a fight because they were loaded, or they were hit by somebody who was loaded, and so forth and so on. So the idea here is to engage the individual quickly with a series of a few number of questions that have a high degree of sensitivity and specificity that look at risky drinking, harmful drinking, and addictive behavior. And the idea here is that the primary care physician, or for that matter, it could even work in dental clinics, that person says, you know, you're drinking this a little bit more, and it may be related to the dental problems I'm seeing. It may be related to the hypertension that I'm noticing here. Have you thought about reducing that, and so forth and so on. So that's the sort of screening. The brief intervention is with people that have a little bit higher problematic use, but aren't all the way to addiction. And there, that's kind of done within the context of that primary care or that health setting. And then if the person does meet diagnoses for alcohol use disorder or cannabis use disorder, they'd be referred to specialty care because that primary care physician wouldn't feel equipped to deal with that. In much the same way that you would refer to somebody, you would refer to an oncologist as if you saw something that you really couldn't work on yourself and indicated that this person needed specialty care. Here's the primary goal. It really is to try to identify people who are moderate or high risk drinking and to help them reduce that so that they are healthier and have less other kinds of problems. Here is a way of thinking about the way that it used to be. You had, if a primary care physician thought that Ron had a substance use disorder, they'd refer him off to traditional treatment where abstinence would be the goal. And if there was no problem, then that would be the end of it. But Esper kind of looks at it a little bit different. This is people who are using in a manner that might be associated with harm to them, health harm, other kinds of harms. And here you do brief intervention and brief treatment. They don't have a chronic disorder. One of the main thing that happens with people that have addictive behavior is that they have loss of control. And they have loss of control because they have that downregulated prefrontal cortex system. And that helps you understand why they continue to use despite the adverse consequences. Plus, those drugs that they're using in that maladaptive pattern have become very important to them. Everybody in the room knows Maslow's hierarchy of needs, right? So at the bottom of the normal person's hierarchy of needs are the behaviors, the things that keep us on the planet. Food, shelter, sex, right? For addicts, there's a level below that. And that's the relationship with their drugs of choice. And people misunderstand addiction as a physical relationship with the substance. It's not. It's an emotional relationship. It helps you understand. These drugs have literally hijacked the brain reward center, and it helps you understand why that newly delivered cocaine-dependent woman leaves the hospital to smoke some crack. She's not doing it because she doesn't love her newborn. She does it because right now, in the throes of active addiction, she loves cocaine more. And so part of addiction treatment is breaking that salience. People that don't have addiction still have some control. And if they don't have control, then they have addiction. So that's how you're able to kind of think about this in terms of brief intervention. So here's the way to think about it. This is the people who are in that green category. They don't need any intervention because they don't have any alcohol or drug problems, right? The people that are on the other end of the spectrum, and that typically represents only about 8 to 10% of the users of that substance. I'll say that again. Only about 8 to 10% of the users of a substance end up with a substance use disorder. The exception to that is nicotine, where the probability of a nicotine use disorder, tobacco use disorder, is much more likely. There are very few just infrequent social users of nicotine. And so in NSBERT, they're trying to intervene with people who are in the abuse or binge use category. Here's just one of the tools that's used. A quick questionnaire is captured. You may have heard of this. It's called the audit. It stands for the Alcohol Use Disorders Inventory Test. And the first three categories are particularly sensitive in looking at harmful use. There are questions about consumption. So this screening tool is referred to as the audit C. And so everybody that's seen in the doctor's office is given this three-question: how often do you drink? How often do you drink 3 times a week or more, and so forth and so on. And those that are in this category that are above these levels. So for me, I'm 68. If I'm drinking more than 7 drinks in a week or more than 3 drinks per day, I would be considered in the misuse category, right? That if I'm drinking within those limits, those are sort of the moderate drinking limits, then there wouldn't be any need for intervention. But if I'm drinking more than that, there's a need for the intervention. And how much more than that I'm drinking would be an indication of how much intervention is necessary. If I'm just drinking a little bit more, I'll use an example. Suppose I have hypertension, and the primary care physician that's treating my hypertension says to me, gives me this questionnaire, and I find out that I'm drinking 12 drinks in a week, and every now and then I'll have 4 drinks on a day. I'll have 2 pints of a microbrew, which would be 4 drinks. And the doc says, you know, Ron, we'd have an easier time controlling your high blood pressure. Maybe you wouldn't need the 2 medications you're on. Maybe you'd only need 1. Maybe you didn't need any. If you cut your drinking back to no more than 7 drinks in a week and never drink more than 3 drinks in a day. And I go, oh, really? I don't like this medication. I don't like the side effects. I'll give that a try. If I'm able to do that, well, I'm not an addict, right? I'm able to control my drinking. And so that's a perfect example of a brief intervention that might be effective for somebody that was just in this misuse category.
A question?
Please.
I'm curious about the 7 drinks per week per women.
Yep.
I mean, that's a glass of wine at dinner each night, and
Yep.
that's on the edge of...
Anything more than that. That's the definition of moderate drinking. And by glass of wine, I mean a 5-ounce glass of wine. I don't mean a 12-ounce tumbler of wine. That's moderate drinking. You tell this to people and they'll go, I thought that everybody that I know drinks more than that. Well, that doesn't mean that that meets the definition of moderate drinking. That's exactly right.
So a woman and a man having dinner,
Mm-hmm.
the man has a higher threshold
Yep.
before it's problematic. That
Yep.
doesn't
You know
seem
why?
fair.
It's not sexism. Really, it's really not. It turns on 2 things. First of all, women, particularly before the age of 65, have less total body water than men. Remember that this is all about blood alcohol concentration. So how much water you have in your system is a determinant of what that blood alcohol concentration is. It's not just how much you drink, but what kind of system you're putting that alcohol into. That's number 1. And number 2, women typically have a decrease in the enzymes that are used to help metabolize alcohol. So alcohol is harder on a woman than on a man, on a dose per dose basis, until you get to 65, and then we're all in the same category. Because as I've aged, I've lost total body water. So me drinking 2 glasses of wine when I was 45 years old is going to have me have less of a blood alcohol concentration than me weighing exactly the same as I did when I was 45 or 48. At 68, I'm going to have a higher blood alcohol concentration just because of that change. Is that helpful? Yeah. I was actually, I got asked that question at another training recently, and I thought, that's not as well known. That information about the differential effects on men and women is not that well known. All right, I'm going to shift gears. I'm off ESPER. This is the Law Enforcement Assisted Diversion. All of these logos that you see there describe all the partners in this. This had its origins in somebody saying, we can't arrest our way out of this drug problem, this open-air drug problem that we're seeing in Seattle anymore. All we do is lock people up and they're out in a day or 2. We've spent a lot of community resources. We've spent prosecuting attorney time. We've spent jail time. Nothing changes. And even if we put people in jail for a longer period of time, their place on the street is taken by somebody else. So is there something that we can do differently? So here are all the partners in this, and Evergreen Treatment Services was hired as the case manager about 2.5 years ago. And here's what we're trying to do with them. So a bike patrol cop in the West Precinct arrests Ron for smoking crack cocaine in the alleyway or shooting heroin in the alleyway. As he's taking him down to the West Precinct, he says, Ron, we have this new program called LEAD. Would you be interested in that? If you opt into that and you're accepted into that, the prosecutor won't file these charges. They'll just hold them for a while. And Ron says yes or Ron says no. And we've had people that say no. So, they don't want to deal with that. And so if they say yes, then our case managers do a psychosocial intake, come up with a service plan. We help people get into motel rooms. We pay for them to get into motel rooms, help them get off the street. We buy them food and clothes, a variety of different things. You can see all of the stuff there. As the process goes forward, we're trying to get them into more stable housing. That can be a challenge because some of our patients have felony arrests, and it's really hard there to get them into some of the houses. Some landlords don't want to take people that have felony records. Here's some more iterations about the kind of things that we do there. You can see that this is, and the hardest thing that we had to explain to the cops was that when they arrested somebody and they opted into leave, we weren't just going to whisk this person away to a residential treatment center where they'd get fixed and they'd have problems before. That this was a long-term engagement, that was building relationships with these people and working on the person that was our principal liaison was then, he was the assistant chief and later became the acting chief, Jim Pugil, and he liked to say, in LEAD, it's kind of like the Hotel California. You can check out, but you can never leave. And we work with our folks for a very long time. Okay, so I'm on the theme of homelessness. I'm going to talk about treatment for people who are homeless who have alcohol use disorders. That's what AUDS means here. And so abstinence-based programs are not well suited. They tend not to go, or if they go, they're turned away because they're stinky, or they drop out because they don't resonate with anything, and the services are not particularly salient to them. They and their colleagues have not responded so well, so many times to these services that they stop going because they don't think that what these agencies have to offer are going to be particularly great. They're not, the services, abstinence-based services are not particularly effective, and in some cases they increase harm. And they increase harm by detoxifying folks, and then when they get back on the street they have a lot higher tolerance, and a lot lower tolerance, and problems occur. I could go on and on. So you don't have this slide. Susan sent me these overnight, and so I'm kind of added to it. This is kind of a review of the data about harm reduction and homeless alcoholics, and you can see all the citations there. I'm not going to spend your time with that. I want to talk a little bit more about what we're doing. So what we're doing in this project, Vivitrol, is that we are both offering people a medication that has been shown to be effective in the treatment of alcoholism, but not from an abstinence standpoint. The medication I'm going to describe only helps reduce craving and reduce the reinforcing properties of alcohol in the person that drinks. And so on this medication, the alcoholic, if they drink less often and they drink less. So that's the harm reduction part. If you can get somebody to drink less often, drink less, you're exposing their organ system to less concentration. And we're coupling that with harm reduction counseling to help the individual kind of think through. And the harm reduction counseling is things such as, for every time you drink alcohol, drink a glass of water. Eat before you drink alcohol. Do things that decrease or minimize the impact of alcohol on that person's brain and liver and so forth and so on. So that's what I mean by harm reduction counseling. The medication that we use is called naltrexone. Naltrexone is an opioid antagonist. You all know what antagonists are. And so in the case of people who are opioid addicts, they have to be detoxified before they can be given this medication. In the case of alcoholics, they don't have to be detoxified. So why is an opioid blocker effective in the treatment of alcoholism? Well, it turns out that there is a subset of alcoholics who actually get an endorphin bump when they drink alcohol. So they're getting a different kind of reward than some of their other alcoholics are getting, who don't get that reward. And if that's the case in that individual, blocking those opioid receptor sites decreases or diminishes the reinforcing properties of beverage alcohol. They don't get the bang for the buck that they're used to getting. And so it becomes less good.
Sorry, how does naltrexone differ from buprenorphine?
Well, buprenorphine is a partial agonist, so it stimulates the receptor site and blocks other opioids from getting on, but still stimulates. You still get CNS depression with buprenorphine. You don't get CNS depression. This simply, the analogy that I like to use for naltrexone, it's like a wad of gum. You can stick a wad of gum, if you think of naltrexone as a wad of gum, in a lock. Think of that lock as a receptor site. That doesn't open the door, but it also doesn't let the key that would open the door get in. That's the difference. Yeah. So you have agonists which mimic the action of a drug. You have partial agonists which do it part of the way, and then you have antagonists which negate or block their thing. So that's what's going on there. The medication that we're using is an extended release formulation. It's a once a month, because our patients, as homeless, would have a difficult time complying with the oral medication, which is a once-a-day kind of thing. The people who do best on oral naltrexone are typically physicians or dentists or nurses or federal probationers who are observed in the daily administration of that. But for homeless folks, it's better to give them a medication for which there's less compliance burden. And that's why we use this injectable formulation. It lasts for an entire month. It's not cheap. It's $1,000 an injection. But if you can offset that person's utilization of an emergency room by one, you've saved money, haven't you? Because most ER visits run between $1,500 and $2,000. That's part of the harm reduction, not just to the individual, but to the community. And here's a kind of a brief overview of the counseling that we're doing. So this is a manualized harm reduction counseling intervention and we're studying it. If you go to that website and read about it, and go to that newly published article, it'll describe kind of in detail what exactly harm reduction counseling leads to. But the intent of this counseling is not about abstinence. There's no insistence that this person quits. It is, let us work with you to help reduce your drinking so it is less harmful to you. Okay, I'm going to stop. I only got a few minutes left, but I'm curious if there are questions. Please.
The drug is really expensive.
Yeah.
So
It's not as expensive as the new oral treatment for hepatitis C, which is $100,000 for 3 months.
What are the numbers on the LEAD program? Do they have research out yet?
Yeah, and so Susan Collins actually is doing the LEAD evaluation. We just got a grant for $500,000 to do the LEAD evaluation. We've treated close to 200 individuals since the inception of this, and we actually had a randomization scheme. I won't bore you with that. So we've got a control group that we can compare the people who got LEAD with the people who didn't get LEAD and see if there are changes in recidivism, changes in utilization of emergency rooms, changes in, I can't remember what the other markers are. So we hope that by November we'll have data that are ready to be published.
When was it implemented?
It was implemented in September of 2012. You know how it goes. I mean, it takes a while to accumulate the participants and analyze the data and all that stuff. But there was a clear intent to do this because it's not happening anywhere. It's happening one other place in the country. The folks in Santa Fe came up here, we went down there, and they started implementing it there. The King County Council actually invested $800,000 to expand LEAD citywide because it was, for the purposes of our research project, our pilot project, it was geographically limited to Belltown. it was kind of a liberal interpretation of where Belltown was, but it was still Belltown. It didn't include Westlake, it didn't include Pioneer Square, it didn't include parts of the International District. It does now. We're hiring 4 new case managers to accommodate that extra need. Please.
Say a patient comes to you and tells you that they have an opioid addiction, but they can't afford traditional treatment. Do you have any recommendations or anything for that, considering withdrawal?
What do you mean, traditional?
Or do you mean, like traditional, like inpatient treatment?
Well, inpatient treatment is terribly ineffective for the treatment of opioid addiction. If you think of addiction as a chronic disorder, it's one thing getting somebody pajamas sober, it's another thing getting them street sober. And so you can go to a fancy place and there's no drugs there and there's no cravings and blah, 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 and it's easy to quit. But detoxification is notoriously ineffective for all forms of addiction, but particularly for opioid addiction. The development of methadone treatment and then later buprenorphine treatment as a replacement therapy was done primarily because of the history of futility in detoxification. If you want to make an opioid addict more vulnerable to overdose, detoxify her.
So what recommendations do you have?
And the recommendation would be to help her or him find a methadone clinic, or find a physician who was doing what's referred to as office-based opioid treatment, or OBOT. That means the prescription of buprenorphine, typically in combination with naloxone, which you know as, by its trade name, I suspect, of Suboxone. Those are the things to do. Sending them to abstinence-based programs are notoriously ineffective. Other questions? Thanks for your time and interest. I appreciate it.